Okay, hello everyone. I think we're about ready to start. Has everyone had a chance to fill out the form? Okay, so we'll come around after Dr. Aaron's session and collect them all from you, okay? So today is an introduction to fibromyalgia management. And as I've already mentioned, we have 3 speakers today. So Dr. Aaron is up first, and then myself, I'm an occupational therapist, and then Rashmi, who is one of our physiotherapists on the rheumatology team. And so our hope and our goal this morning is to provide you with some base information about what is fibromyalgia, what does it mean, and how do we begin to manage it. And that we recognize that this is a journey, and this is just one piece of it. And so that is why we are so excited to have people from the community here with us today, because it just helps to strengthen our links to community and community programs that are out there that can help you as you continue your journey in managing fibromyalgia. Okay? And so there is an evaluation form in your book as well. And so at the end of the morning, we hope you will take a couple of minutes to fill that out and to give that off to us. Okay? Alrighty, thank you. With that, I will pass it over.
Thank you very much. Welcome. I'm Dr. Stephen Aaron. I'm a rheumatologist here at the University of Alberta. Some background into what we know and don't know about fibromyalgia. It's not going to be cast in stone. We don't know everything about fibromyalgia, and therefore the approach that I take is to give you some idea about how we know what we know, how you should evaluate information that you hear about fibromyalgia to see whether it's believable or not, and to give you some reassurance that even though we don't know everything about it, there's a lot of research going on into it. And so it's being taken very seriously. We're really working to try to understand it better. There's just a couple of ground rules today. I will be asking the audience some questions, but if you feel at all uncomfortable about putting up your hand or saying anything, that's fine. That's absolutely fine. That's okay. The second ground rule is that although I'll be giving you lots of opportunity to ask me questions, I can't respond to individual questions about how each of you should be treated or whether your treatment is appropriate, A, because I don't know you all, and B, because that's your own confidential information and really can't be discussed openly. Even more so because we're recording this, so you don't want to have that put up on the web for everybody in the world to see. So, but I will answer general questions in terms of principles, in terms of why something might be the way it is. And of course, if I say we don't know, it's because we're still doing research on that. So I'm going to start by asking a question. I know that some people are here with family members, but how many here have been told they have fibromyalgia? Well, that's a lot of people with fibromyalgia. Just out of interest, how many of you, in retrospect, have had that discomfort for more than 5 years? So just about everybody. How many of you do you feel it took quite a long time to make that diagnosis? Okay, so that hasn't changed over the years that I've been asking these questions. So to summarize, this is a very, very common problem. We believe it's been around for a very long time, but it's been very difficult from the time it's been recognized to figure out what it is. And I'm going to tell you a story about the discovery of fibromyalgia, and I'm going to explain some terms as I go. And if at any point I start to lose you, please just pick up your hand and ask a question, because if you don't understand, probably lots of other people don't either. So that's okay. But I'm going to start with something different than fibromyalgia, just to give you a sense of medical terminology and how it works. I'm going to write this word down. Arthritis. What does that mean? Inflammation of a joint. And this is how it works. To make ourselves sound smart, what doctors do is we tend to use the Latin word for a part of the body. So arthris is the Latin word for joint. And if there's inflammation, we add this thing after it means itis. Now, inflammation implies something you can visualize as red, puffy, swollen, hot. It's often from infection, but it can be from other things. So if you have inflamed tonsils, we call it tonsillitis. if you have an inflamed appendix, we call it appendicitis. Real simple stuff, it just makes us sound smarter. For a very long time, there wasn't much that anybody could do about arthritis. So we tended to call everything that hurt, that was in a bone or a joint or an arm or a leg, we tend to just lump it in with arthritis. And if we couldn't call it arthritis, we called it something that we actually don't use anymore, called rheumatism. Nobody uses that term anymore. But it was used until so recently that until maybe 3 years ago, the major journal, medical journal in my area was called Arthritis and Rheumatism. And we used to treat it all the same. Everybody would get painkillers and aspirin. In about the 1950s and 60s, there came about a big change in the available treatments for arthritis. And it became pretty obvious in the 1960s that there were some people who are lumped in there who just don't get better with those treatments for arthritis. So a number of doctors, including predominantly some Canadians, looked at these patients and found the following: that a lot of these patients had widespread pain. So pain, not just in one area, but usually in lots of areas, and sometimes not even in joints, like headache, stomach pains, things like this. That they slept poorly, and were often tired much of the time, and were tender, but the maximum tenderness tended to be in muscles. Now, he wanted to make up a new word for this. Muscles are made up of fibers. So he guessed that it was an inflammation disease, and he called it fibromyalgia. That was about 1967, and there was a light bulb going off in the minds of a lot of doctors all over the world, and everybody agreed that they're seeing these same patients themselves. But nobody knew it was from. So that was 1967. That was about 50 years ago. God, it's a long time. What I'm going to do is I'm going to go over what we now know from that after 50 years. So far sounds relatively familiar. So I'm going to talk about two methods of medical research. One is the kind that you see around you in this massive set of buildings here, where we do research using electron microscopes and MRIs and DNA techniques and biology on little bits of the body, so that there's a GI building and there's a heart building and there's a neurology building. We take people apart and we look at little parts to the nth degree. And then I'm going to talk to you about another kind of medical research which was very popular many years ago and is now more popular again. But we're going to see how each of these techniques has been used to understand what is going on with this disease. Okay? I'll take you back to the 1960s and 70s. And this is going to be a big embarrassment for me because this terrible drawing is going to exist forever. So let's say that this is your thumb. There's your thumbnail. And we'll say, for the sake of argument, that something's going on in your thumb, we think. And it's connected by nerves up your spinal cord. I'll explain what these things are in a minute. And then goes to your brain where, I'm having pain. So the initial guess was that where you felt the pain, there was something wrong with your muscles. Could be in the joints, could be in the skin, could be in the blood vessels, could be in the bone, could be in the nerves. And the initial proposition was that this was not arthritis because we separated these people from those with arthritis because they didn't get better the way arthritis does. So right from the beginning, we figured it wasn't a joint problem. It was different than a joint problem. And the first guess was that it was a muscle problem. So for about 20 years, they looked at muscles under the microscope. They did electrical studies of muscles. They looked at muscles using other techniques, and after 20 years, they finally decided this was not really a muscle disease. So after 20 years, the major progress that we had with this disease is they changed the name from fibrositis, implying muscle inflammation, to fibromyalgia, which essentially is more vague and said a disease where you have pain in muscles. That was it. 20 years worth of research, and that's what they came up with. There's been research into whether or not this is a bone problem, a blood vessel problem, a skin problem, and the kind of nerve problem where, like multiple sclerosis, where the nerves are damaged. None of those has worked out. However, in this millennium, there have been much changes in the way that we look at the way the nervous system works. And I'm going to go over some technology with you because it's quite important for the understanding. So this is your brain, left side, right side of your brain, and you have the area that responds to pain here. The nerves go down the spinal cord, and then they go down to wherever, say it's your thumb. And there are a number of places where that signal is transmitted from one nerve to the other. It's been known since the American Civil War that these nerves can be permanently turned on or turned off because of these signals here. Has anybody heard about something called phantom limb syndrome? Okay. Phantom limb syndrome was described first in the American Civil War because of the massive number of battlefield amputations where people's pain would continue even though the limb was gone. And it's been described ever since. There was a lot of work on it done in recent Middle East wars, and we believe that it's due to changes in the way that these nerves function in the spinal cord and brain. The reason that we can tell this kind of thing without taking people apart while they're living is because of technology that can actually look at the signals going on in the brain and spinal cord while you're thinking. And that is a kind of MRI. Now, you know what an MRI is. It's the way you put your head in a big magnetic donut, and you can see what's going on. Now, ordinary MRIs, like are available if you get booked for one here at the hospital, look at structure. They can pick up a hemorrhage, a stroke, a brain tumor. They can't tell what you're thinking or feeling. But a functional MRI, which is only available in a few research institutes, looks at how active parts of your brain are. And they are pretty good at picking up whether or not you are having pain that is reflected in areas of discomfort somewhere in your body. And the interesting thing about this is that it's not just that there's a signal one place in your body, in your brain, but there's signals in several parts of your brain at the same time. So that if this is the part of your brain that feels your right thumb, there's also signals at the base of the brain that's responsible for unpleasantness. And both of these things are on at the same time. Several studies have showed that in people who have pain, you get these two signals at the same time. If you've got phantom limb syndrome, they're always on at the same time. But that's also the case when people do research in fibromyalgia. The signals are on, and they stay on. So if I don't have fibromyalgia, and I volunteer to put my hand in ice water, which hurts, and you're doing a functional MRI, those signals will go on, but when I take my hand out, it goes off. In fibromyalgia, it doesn't go off. It's very analogous to the phantom limb thing, where the signals don't go off. This has been corroborated in a limited way by more unpleasant research, where people have volunteered to have spinal taps. You know what a spinal tap is? They put a needle in, they take out a sample of the fluid that's around the brain, and again, they see an increase in chemicals that tend to go up when people have pain. Now, why might this be? So, in order to get into this a little bit more, I'm going to talk to you a little bit about how nerves work. It's really fairly straightforward. So you've got a nerve. You can think of it as being like a wire. It transmits electrical signals. At the end of that nerve, there's a bulb, and then at the other end, there's another nerve with another bulb. Essentially, the nerve simply transmits electricity down here. But this is more like a transistor or a switch. So it's not automatic that the signals go from one nerve to the other. It can be controlled. And the way it's controlled is this. So you've got electricity going down here. It triggers the release of little packets of chemicals across that gap. Those are called neurotransmitters. And if the neurotransmitter is released, the second nerve gets triggered and you got an electrical signal down there. Okay? Everything that you do operates like that. There's a neurotransmitter between your nerves and your muscles. There's a neurotransmitter between the cells in your eye that feel light and in the brain where you see light. There are neurotransmitters working in multiple systems. But there are some key neurotransmitters that work on certain systems. So let me give you a really common example of one that is around and functioning in this system, and that's called serotonin. Serotonin is sometimes thought as being the happy hormone. So way back, even in the 1960s and 70s, it was recognized that serotonin is active in a lot of related areas. Pain is one, mood is another, sleep is a third. People who have pain tend to have lower levels of serotonin. They tend to have more pain and poor mood, and so drugs came about to modify whether or not serotonin moved across this membrane. This can be modified like a transistor, either up or down. Okay, so let's review. It's believed that it may be that fibromyalgia is due to some chemical problem or nerve transmission problem where you're either getting too much pain signal or not enough inhibition of pain signal. And so they started guessing, even before the MRIs and other things, back in the 70s and 80s, that it might be a problem with this serotonin. And there were drugs available to increase serotonin, so they tried. And the first one they tried was a drug called amitriptyline, which is also known as Elavil. It was one of the first antidepressants, but aside from antidepressant, it increases serotonin level. And generally speaking, if you took 100 people with fibromyalgia and you gave 50 of them this drug, on average, a little bit, that 50 will do better than the 50 you don't get it. Not massive, but some effect. So it was the first drug specifically being used for fibromyalgia, not perfect. The side effects. These drugs tend to make you drowsy, because I said serotonin affects sleep. Next approach. Epilepsy is a disease in which there's too much sudden electrical signal. You get a massive release of electrical energy going through a lot of these nerves all at the same time. So drugs were developed to treat epilepsy And the way they work is they don't work on the chemistry here, they work on the electrical signal here. So somebody came up with the idea that maybe if we slowed down the electrical signal, we would slow down the pain signal. That was used for people who have nerve diseases like diabetic neuropathy, which is a nerve problem, but also in fibromyalgia with some benefit. The first one that was used for that was a drug called Neurontin, which had been in use for quite a long time as an anti-epilepsy medication. Now, the drug companies are not stupid. Drug companies recognize that this is a common problem. Chronic pain is a huge problem, and there's a lot of people who have it. So the drug companies have been working in your favor, I must say, to try to develop more specific targeted treatments in these two measures. So you may have heard of these before, but this is how they work. So one of them is called duloxetine. The brand name is Cymbalta. You've seen it advertised on television because they say depression hurts, right? That's why they're saying it that way, is because it increases serotonin levels in a more novel way. It therefore improves mood, but it also treats pain. And it treats pain so widely that it is now approved by the FDA in the United States for treatment of such things as osteoarthritis as well as fibromyalgia. Pregabalin is a fancy neurontin. It is modeled on the drug that slows nerve conduction. It is now approved for use as Lyrica for both diabetic neuropathy and fibromyalgia. Now, the problem is that these neurotransmitters exist across multiple systems. And any drug that slows down nerve conduction somewhere that you want it to might slow down nerve conduction somewhere where you don't want it to, including pain, but also sleep, too much sleepiness, too much drowsiness, dopiness, other side effects. So we don't have the so-called magic bullet, the thing that's completely targeted and does exactly what it wants to. So, to summarize, the only consistent evidence about where fibromyalgia exists seems to fit with the idea that it's in the signaling process itself, rather than in the tissues where you seem to have the pain that the problem lies. It's very likely electrical and chemical, and it's very likely that there may be multiple ways that people get that problem. We don't understand them completely. But to understand them better, I'm going to leave this kind of targeted specific tissue research and go to a very, very old-fashioned way of looking at disease. But before I do, are there any questions here? If you have any, come back to me later. Okay, I'm going to say something inflammatory. Oh, no, inflammatory. I'm going to say I'm your next door neighbor. And I said, you're telling me you're in pain, but you can walk. I don't see any rash. I don't see, that you're paralyzed or anything. How do I know that you really got a problem and that you're not making it up? I know maybe nobody's ever said that to you directly, but have you ever got the impression that maybe people are thinking that? Okay, so I'm going to tell you about a form of research that demonstrates that people just don't go to doctor's office and claim they're hurting everywhere because they want a sick note or a disability note. I'm going to show you research that indicates that's not likely the case, but it's not going to be research on individual patients. It's going to be epidemiology. Epidemiology is very powerful. Epidemiology is the study of populations rather than individuals. And it's probably responsible for saving more lives than any medicine around. Going back to London at the time of plagues and cholera, where before they even knew what a bacteria was, they recognized that you're more likely to die of cholera if you live near a well. And they thought, there's something going on here, so we're going to build a sewer system and save lives. That was based on population statistics rather than looking through a microscope. So I'll go show you an experiment that actually took place in London, Ontario. So London is a city of about 200,000. One of my older colleagues, this is several years ago, decided he would get some summer students. And before there was internet, he used the phone book. They called up people at random through the phone book and asked a few questions. The most important question, have you been in pain over the last 6 months? And they found out that about 12% of the people they called said yes. That's not a huge number, but it's the case. Chronic pain is very common. So let's say they got 1,000 people who said yes. Or they called initially 1,000 people. So out of those 1,000 people, that means that 120 said yes, they have pain. They invited those 120 to come in to the University of Western Ontario to be examined. So out of those 120 people, 20 had fibromyalgia, which is 2% of the population they called. So assuming this is a random population, 2% of the population of London, Ontario has fibromyalgia. Every population studied, it's around 2%. I don't care if you're in Africa, Europe, and Asia, anywhere, it's about 2%. Here's the really interesting part. Almost none of those people ever went to their doctor about it. They didn't go to somebody complaining and wanting a sick note or a disability form. They just have it. It doesn't matter how you do this, people have it. It's not something that doctors are saying, I think you have fibromyalgia and they invented this problem. It's there. So if it's been there, why was this only discovered in 1967? Well, it's because we called it rheumatism. Remember I said that old rheumatism that we don't believe in anymore? It's gone from the literature. We now think that that's fibromyalgia. And it's been around forever. And it's everywhere. You see it more in some places because there's more doctors to diagnose it some places. I'm sure migraine is common in Africa, but you don't get to see a doctor in Africa unless you die. So you're not going to see a lot of people diagnosed as migraine in parts of Africa. So can we use this technique to tell us more about fibromyalgia? Well, actually, yes, very, very, very powerfully. Now, let's say that I wanted to prove that a disease had a genetic component, that it was due to something genetic. Now, there isn't much, we call it organic, in other words, an actual physical cause for a disease, something that is hard as a DNA in your body that you were born with. Well, actually, you can do that very well with these studies. So we go to Finland. In Finland, they have a national healthcare system that has very good data. So they track all diagnoses, and very importantly, they track all twin births. And you can go into a computer and you can check on these people and see. So this is how they work. You get a big register of lots and lots of people who have fibromyalgia and have a twin. So you take the first twin and you say, I have a twin who's got fibromyalgia. So there's two kinds of twins. What are they? Do you know what kind of twins? Right. So some of them have an identical twin. Some of them have a fraternal twin. Now, an identical twin has exactly the same genes. The fraternal twin has about 50%. So a well-established way of finding out whether a disease has a genetic component is to compare in these sets which of the twin kinds are more likely to have fibromyalgia. Care to take a guess which one was more common? The identical, by a significant amount. Big numbers. Really strongly suggests that fibromyalgia has a genetic component. Not 100%. Not 100% of these identical twins got it. But it says a lot more. Let's say that you are going to argue that fibromyalgia was almost completely due to some kind of bad parenting, childhood trauma, lousy schools, socioeconomic thing, you would expect, because both identical and fraternal twins were raised in the same environment, you wouldn't see that difference. But you do. Okay, now, this is one of those questions where you don't have to put up your hand if you don't want to. But does anybody else have somebody else in the family who's got fibromyalgia? Yeah, quite a few, not everybody. So there are probably different ways of getting there. Now, this is where I'm really going to push a little bit, because I want to explain to you why this fits so well with the other model about the problems with the neurotransmitters. Does anybody know how a gene affects your body? What does a gene do? Gene is a set of DNA. Anybody remember from high school chemistry or biochemistry or biology what a gene does? Genes code for proteins. So let's say you've got cystic fibrosis, which is a genetic disease. You have cystic fibrosis because the gene for a protein in your lung is not making that protein. You got a faulty gene. You're not making a protein and you get lung disease. So neurotransmitters are proteins. So it's a simple guess, but an intriguing one, that the genetic predisposition to fibromyalgia is due to a faulty production of a neurotransmitter. And those functional MRIs are now getting to the point where they can actually measure chemicals like that in the brain without actually having to have a brain biopsy. So the ideas about how these diseases work are starting to mesh. Now, something else happens. We know that fibromyalgia is far more common in people who have some other chronic disease. So I look after people who have rheumatoid arthritis and lupus. 2% of the general population has fibromyalgia. 20% of people who have lupus or rheumatoid arthritis have fibromyalgia. That doesn't mean if you have fibromyalgia, lupus, or rheumatoid, those are rare. But something happens. Now, here's where I'm pushing my guesswork. I'm guessing that having a chronic disease and feeling crummy for a long period of time can operate like phantom limb syndrome. It can turn these nerves on, and in the right setting, you don't have the right chemistry to turn the nerves off again. This is starting to be a common theme. Yeah?
Is fibromyalgia common with people with scleroderma?
It's common with people with any chronic disease. I see people who have fibromyalgia after they've had a bout with breast cancer. They feel all that chemo, they feel crummy, their oncologist tells them the cancer's gone, but they don't feel good right away because it takes a long time for everything to go back to the way it was. So yeah, absolutely. So when you learn how to do anything, you learn how to throw a basketball, you learn how to do times tables, you learn anything, nerves become connected to other nerves. So the more often you make that connection, the more often you throw the basketball, the more you ride a bike, the less likely your brain is ever to forget that connection. So there's a strong idea here that if you've had pain in your left leg long enough before it's amputated, your brain has learned that where that leg was, that was pain. And it stayed there. What can we do about that? Well, I talked about using chemicals to dull that connection. But there is good reason to think that you can do this on your own and unlearn those connections. I'll give you an example of an interesting technique in phantom limb syndrome. So let's say, for the sake of argument, that my left leg was mangled, it was in pain. It was in pain quite a long time before it got amputated. And now my brain thinks that I still have my left leg and it's pain. Here's what they do. They put me in a box. So in the box, I put my left leg in that box. But there's also a mirror in that box so that where I see my left leg, I actually see my right leg, which is normal. Then they get me to move my right leg, and I'm watching, and it looks to my brain like I'm moving my left leg. You do that enough times, the brain seems to learn that your left leg is okay. And it gets better. So it's like unlearning a memory. And we know that in general, the right kind of exercise improves fibromyalgia. Nobody really understands why that is. That's a guess on my part, but it's a hypothesis that if you have connections that you don't want, the only way to get rid of connections you don't want is to generate connections you do want, is relearn. So it's pushing the boundaries a little bit of guesswork on my part here, but it's well established that the foundation for fibromyalgia is difficult as it is, as tired and painful as you are, is to keep moving, which is where I hand it off to my colleagues both here and outside. But let me summarize and then leave lots of time for questions. We've been spending 50 years trying to understand this thing that was defined in 67, but it's probably been around forever. There's almost certainly some kind of chemical and electrical thing going wrong. To explain this, we have some new tools to look at it, but the research is still really, really early. Drug companies aren't stupid. They know that there's a big market. They're motivated by profit, but nonetheless, they fund a lot of that research, and they really want to do something better. And I applaud that. But medications will always have their downside. It's really important for you, as it is for people who have diabetes or any other chronic disease, to recognize that a lot of the management of these kinds of diseases is self-management. The exercise, the managing your life with a chronic disease, trying to figure out how to maximize your energy levels, make sure you build in healthy stuff into your life, like exercise that is good for it. That your life isn't put on hold by having a chronic disease and you're able to function. That's really important because as much as we would like to have a cure for this tomorrow, what I'm explaining is we're working on it, but it's going to take a while to get to that point. I'd like you to be relatively critical in analyzing what people tell you. There's a lot of well-meaning people who want to tell you about all kinds of things that have worked for them. But like in most diseases, people have ups and downs. And if somebody believes that something is responsible for their up, they'll tell you about it. That's called anecdotal evidence. It doesn't mean it's wrong, but it doesn't necessarily mean it'll work for you. I'd like you to be critical in analyzing that, particularly if that thing is potentially harmful to you, like taking too much of certain kinds of medications, or if it's particularly expensive to you and hasn't been proven. Because people might take advantage. I mean, I'll be blunt. There are people who want to take advantage. Analyze the literature carefully. The kinds of research that we believe the most in are called controlled studies, where people don't know whether they're getting a placebo or the real treatment, and neither do the people looking at whether they're getting better or not until they break that code. Now that's our gold standard of saying whether something works. There's really very little downside to exercise, as difficult as it is. And even the medications I just talked to you about, they're approved as being probably helpful, but they have their downside as to other drugs. I could talk more, but I think that's the critical thing there is take everything with a grain of salt. Some of the patients who I've seen who've done the best are the ones who've been very critical about what medications they take and have been very critical about doctors' advice, knowing that we can't say that we know everything about this. So are there any questions? Yeah.
I have one question. I think it's going back to the on-off switches and neurotransmitters and electrical signals. The studies indicated at all that glaucoma is related to epilepsy?
So the question is, given that there's neurologic involvement, is it related to epilepsy? It's not. It's just that epilepsy has shown us that there are ways to modify nerve signals to slow nerves down. So that's been very helpful in other kinds of diseases where we think there's too much nerve signal, but it's not related to epilepsy in that way. Yes?
How you say this fibromyalgia seems to have been developed and works coinciding with another chronic disease. Have they completed studies on like a trigger point or an accident that would bring on fibromyalgia?
So the question is whether accidents can trigger fibromyalgia. This is really controversial. And you know why it's controversial? It's controversial because it gets into litigation and law. And their insurance companies are terrified of that. The difficulty comes from the issue about whether or not that person had the problem before the accident, and nobody has access to you before the accident. That's the trouble. I have to tell you that my personal belief is that it can, and the reason I think it can is because I think personally that there's probably not a lot of difference in some ways between fibromyalgia changes in the brain and post-traumatic stress disorder changes in the brain. One manifests itself as imposition of conscious memory of an event. The other one is imposition of painful memory of an event. And my bias is that I don't think chemically there's a big difference between those things. So it hasn't been absolutely proven. I suspect it is the case. But you know, the trouble is that people are lab animals. You can't subject people to trauma and then see what happens. The interesting thing is that there are certain kinds of accidents that are more likely to trigger chronic pain. So, for example, if you break a leg, you're much less likely to get chronic pain than if you have a neck injury. And nobody understands why that is. Until we understand that, we can't really figure out why.
So it's like being post-traumatic stress syndrome is quite similar to being stuck in fight or flight.
That's it, yeah. Yes?
What's the difference between fibromyalgia
And
and MS?
oh, big difference between fibromyalgia and MS. Fibromyalgia is a kind of disorder where things are not working well, but structurally they're intact. That's why it's been so hard to get some people to take it seriously, because there's no damage. The analogy I use is between migraine and stroke. In migraine, you have terrible pain, it can last your whole life, it's on and off, it's really bad. It can really make your life miserable, but you look at the structure and it's fine. It's in the electrical signals and the chemistry, just like this. So it doesn't show up structurally different. MS completely destroys nerves. Never come back again, which is sad, but that's the difference. And it's caused by a cause that we understand a little better, which is immune system damage. That's bad. But at least it allows you to say, if I trigger the immune system, I can stop the damage. We're not that far. There was a question up there.
So why wouldn't a neurologist treat fibromyalgia if it has something to do with nerves?
It's very interesting. Medicine is not everything we do in medicine makes sense. It's often cultural and historical. So fibromyalgia was first described by a rheumatologist because it presented as the kind of pain that we look after, bone and joint pain. And so we've done the most research in it. But there's a further answer to your question. People with fibromyalgia are more likely also to have headache, or bladder discomfort, or bowel discomfort, which makes sense because what we've been saying is that fibromyalgia isn't about the bone or the joint, it's about the way that pain has affected somebody. And it doesn't matter what part of your body, that pain may affect that other part of your body. So what we find is that the way we've divided people into little bits and super specialists ultimately is wrong. People are whole. So our little divisions by system, don't always work.
The effects are so similar to MS though.
It's often,
very similar.
that's right. So what happens is somebody comes to a doctor and thinks they have arthritis. and we examine them and say, no, it's fibromyalgia. But somebody can also say, I think I have MS, and it's fibromyalgia, and that's because the pain may have that characteristic of nerve pain. So there's some other questions? Yes.
So given your hypothesis that you mentioned earlier about being able to break those connections, what's your opinion of fibromyalgia being is a chronic condition? Can you get rid of it? Is it a flare-up condition? Is it lifelong?
I'm going to show you an optimistic piece of research.
Okay.
Anecdotally, I know people who get better. I probably am underestimating the number of people who get better because if somebody doesn't want to come see me anymore, I don't know if they're just frustrated with me or they're better. But part of that research in London, Ontario did this. So they also looked at the age of people who have chronic pain. And if this is age, let's say this is 30, 40, 50, 60, etc. And this is the percentage of people at each age who have chronic pain. So let's say 5, 10, 15, 20. It goes like this. Now, why might fewer people as they get older have chronic pain?
Aging?
Less stress.
The muscles. They can't remember.
Well, I'll tell you, let me tell you the worst possible case. I'll tell you the worst possible case. The worst possible case is that having chronic pain in earlier life predicts you'll die by the time you get to this age. So you disappear. It's not the case. It's not the case. It does appear as if for any of the reasons you're talking about, stress or whatever, that people actually might improve with time. Now, it doesn't mean just because the graph peaks at 50 that you have to wait till you're 50 to get better. It just means that there are people at certain times who do improve. It tends to be up and down. It tends to come and go. It tends to be gone for a while and you think, thank God, and then it comes back again. Just so you don't think that this is the only problem like that, let me tell you a little bit about the following. Fibromyalgia is more common in women. We don't know why. Chronic back pain is more common in men. Now, because men have it, men will have you believe that chronic back pain is a more definite physical problem. Those discs are all degenerated and all that kind of stuff. Don't believe it. Chronic back pain isn't understood by doctors either. And it can't be explained completely by what you see on an MRI. We think that when I said that 12% of the people of London, Ontario have chronic pain, and only 1/6 of those have fibromyalgia, what's wrong with the other 10%? Well, they have things like migraine, other forms of chronic headache, chronic abdominal pain, chronic back pain. When I said that chronic pain is a huge problem, it's a huge problem. Virtually everything that I'm saying about fibromyalgia goes for other forms of chronic pain. We don't understand it. We're treating it as a profession badly. We're either giving way too many of the wrong kind of drugs for it and causing a bigger problem, or we're unsympathetic to people and not giving them anything at all. We're really bad at it. And I don't care whether you call it people doing research in it, neurologists or gastroenterologists or rheumatologists or other people. We need to talk to each other more because I suspect that eventually we'll come to the same place and recognize that we have similar treatments to offer and they can work. But it's a really common problem, but it's not dismal. Yeah?
In your opinion, can you use diet, or is diet a cause?
Not probable. The first line of evidence that suggests that diet is probably not big is because the first reason we thought diet was important for other diseases is it was noted that diseases were different depending on where you came from in the world. So, for example, Eskimos didn't used to get heart disease. Ergo, fish oil is good for your heart. Okay? That certain people got certain kinds of stomach cancers. That diet was bad for stomach cancers. But that's not true of this, and therefore it's probably not the case. The second thing is a little bit more philosophical on my part. There's been no study showing that diet makes a big difference to fibromyalgia. I have a big thing, I love food. I'm lucky, I don't gain that much weight, but I love food. And if I had a disease that was already restricting my life, and one of the nice things about it is that I like to eat certain things, the last thing in the world I would want to do is have that disease wreck something else that was good about my life. So eat healthy for the things that we know that diet is good for. Calcium for osteoporosis, low sugar and salt for your heart, but otherwise, eat healthy for that and enjoy your life. But it will make a difference here. Yeah.
If what you're saying is that diet has no, why is the first thing the doctors tell you is to watch your diet and your exercise level?
Well, exercise, first of all, is good for this. I think the message isn't made clear.
Yeah, for sure not.
Well, let me put it to you this way. One of the problems with fibromyalgia is that you may not be getting as much exercise. You've got to look after your health as a whole, right? So you should be making sure that at least you're healthy otherwise. So what I'm saying is, yeah, eat healthy for those things that we know are good for your health. I don't know if you've gone into this. It's complex carbohydrate, no sugars, reasonable for fat, all that kind of stuff. But that's not going to cure the fibromyalgia. It's just good for you otherwise. Yeah.
So I'm not sure if I'm going to be able to ask this appropriately, but in your experience with patients with fibromyalgia, are you seeing kind of flare and remission at all, throughout the years, or is it more of kind of with chronic pain, somebody lives 7 out of 10, and with different regimes, you can kind of get them to a 4 out of 10 living with pain, and that's the improvement that they see? Or is it kind of
It varies hugely between people.
Okay.
And there aren't really as good studies as there should be. And the reason is that, remember, I only see the people who come to me and are referred to me. Remember I said that there's a lot of people out there that we don't see? I can't answer your question until somebody does a very, very well-conducted big study out in the community looking at people and seeing what happens. I'm more likely to see people who have more severe problems. But I do see people who find a regimen on their own of exercise. I'll give you an example. I find that when you're tired and you're busy and you're not feeling well, it takes a huge amount of willpower to then add something to your schedule, like going and exercising. That's me. I know me. That's me. So what I've done often, and it does work for some people, I can't say it works for everybody, is I say, well, in that case, modify what you do already to build in some more exercise. I remember one young university student, I know where she lived. I said, walk to school. You have to go to university anyway. Don't get mom to drive you, walk to school. This kind of thing, I find, it may work a little better for people who can't be motivated to schedule it in. And I think those people, I think, have done better that way. I think it's good for everybody. It's good for me because I have a tendency not to exercise. So. But it's really important that you schedule and budget your time. So one thing I'm going to tell you is you have to look after yourself. Now that's true of diabetics. I'm sure there's somebody here with diabetes, and I'm going to ask, but it's a common disease. I'm sure you've been told you need to exercise, you need to watch your diet, you need to do things the doctor can't do for you. What I'm going to say is that's the same thing here. It's the same with any kind of chronic disease. We can prescribe it. There's certain things that you do. One of the things that's really critical that you do, maybe in the way I just said by building it into your schedule, is regularly move. You may still have flares. You may not be perfect, but I can pretty much guarantee that if you do, you'll be better than if you didn't. You'll be better than if you hadn't. And it may mean that there are certain other things in your life that aren't perfect. One thing that I've seen with a lot of women is they have a huge amount of guilt because they aren't doing as much as they used to before. Cleaning up the whole house, making all the beds, doing all the other stuff, plus having a full-time job. And something's going to give. But you're not going to do anything for anybody if you're not healthy yourself. So it's really critical think as if you had diabetes or these other diseases. It wouldn't be an option. It would be a given. The doctor prescribed you have to take some time for yourself. And whatever energy you have in your day, some of that energy should be spent on some kind of exercise. Now, whether that's built in, like walking to work, or if it's something that you can do at home, like a treadmill, or if you are the kind of person who enjoys going to the gym and that's really good, it makes you feel good, then do it. But one thing or another, that's a given, that's a prescription. You got to do that.
Do you know why, like, fibromyalgia, why would your pain rate get so high that you literally just want to scream and scream because there's nothing more you can do about the pain, and then all of a sudden it's just like, it's kind of like being in childbirth. That's the only way I can explain it. And then all of a sudden, you finally have the frickin' baby, you know, and then the pain kind of starts going. Like, what?
Well, we don't know. I mean, there are researchers who believe they know what they would see going on in your brain during that. What they would see is what they do is they measure the amount of oxygen that parts of your brain use when they're active, and they would see several areas of your brain light up at once. You know, the area that represents the sensation from that part of your body, as well as areas that signal unpleasantness deep in the brain. But we don't know why. We understand that the brain's an electrical organ, and therefore chemically and electrically something must be going on there. But it's somebody asked about the relationship to epilepsy. Maybe I'll back up a bit. It's like spontaneously those signals are going off. But we don't know that it's like epilepsy where there's a scar or something that triggers it. We don't know. Remember I said at some point I'll have to say I don't know. This is the one where I say I don't know.
Does fibromyalgia and celiac have anything to do with each other?
Celiac is one of those diseases where a lot of people have celiac have a lot of chronic pain. And I suspect that a lot of that tends to be fibromyalgia. We don't know why. Celiac is a funny disease. Well, not funny, haha. It's an unusual disorder where people do have a lot of other problems. I have patients who I see for rheumatoid. The guy was losing weight, and I did a test, he had celiac disease. He was aching all over, he was miserable. And he's now better, we treated his celiac disease. I suspect you're right. I don't.
Changed my notes to.
Yeah. So I have time for one more question. Who hasn't answered? This lady hasn't asked a question.
No, I have two questions actually. No, just a follow-up with when you said about the diet, and you mentioned earlier that the serotonin, helps a little bit. Is there anything that can, include in the diet that will increase the serotonin, even if it helps 1%?
Okay,
Another question?
I'm on thin ice there. I'll answer that one first because I'll forget the first question.
Okay.
There's some evidence that the kind of thing you get like hot milk, like tryptophan, has a similar effect to serotonin, which is why warm milk helps you sleep. So it's a little similar. So what's your next question?
Okay, some also from the chronic diseases, like sleep poorly and the tiredness and this, it's hypothyroid. So how can you differentiate? How can you tell if you have a hypothyroid or you have a...
That's a really good question. That's a very good question. There are some people who say that everybody who looks like they have fibromyalgia should be screened for thyroid. Thyroid is one of the most common tests done in Alberta. It's huge. Most people here, I bet, have had a thyroid test done. Generally speaking, I'm not keen on cookbook approaches to disease, but if there are other signs of thyroid disease, hair loss, unexpected weight gain, certain physical findings, yeah, I mean, there can be some overlap between those. Now, I'm going to have to beg off now because I have some other things. It's been really great talking to you. I'm sure some of the questions you have may be answered further on this morning, but good luck. And if I'm going to reiterate anything I want to today is there is huge evidence that this is a genuine problem with a genetic underpinning in many people that we don't understand enough, but I guarantee to you that there are lots of people doing research on this who haven't been forgotten, and hopefully we'll make more progress. But in the meantime, make the most out of what you can of your life. Exercise, I'll focus on that. Exercise is really important to your health. Thank you.